And then once you graduate PA school, like your loans may be allocated up until when you graduate, right? And if you graduate end of July, you have all August, all of September, October. I mean, that's 3 months before
Right.
you, and then you may not get paid right away starting a new job. That's, 3+ months that you go with.
Hi everyone, welcome to eShadowing. Hey guys, as you all know, I'm Rodalyn. I am the host of eShadowing. Welcome back. There was no eShadowing last week, but we're back today. And today we have David Whisenant. Thank you so much, David, for coming on.
Yeah, thanks for having me.
Great, great. David is a PA, as you all know. He has a background in orthopedic surgery and urgent care, which he presently does. So we're excited to have him here. Thank you again for coming, and we're excited to learn about your PA journey and how you got to where you are and everything you did and getting all your awesome advice.
All right, let's do it.
All righty. So can you start by telling us about your pre-PA journey, how you learned about the career, and why you chose PA?
Yeah, sure. So that's a good question. So my pre-PA journey started kind of in undergraduate. I did my undergraduate degree at Michigan State University in athletic training. So I've always sort of been around medical providers and healthcare of some sort, even since undergraduate. So I worked as an athletic trainer for a few years. I did my first master's in athletic training at UCF in Orlando. In both undergrad and in grad school. I worked closely with some PAs as well as physicians that worked with the sports teams for the universities. So I had some exposure to PAs, kind of early on and throughout the early part of my career. And then it kind of bounced around to a couple of different opportunities and ended up finding a job in an orthopedic surgery practice as an athletic trainer. So I worked one-on-one with an orthopedic surgeon in clinic as well as in the OR. So as an athletic trainer, I was taught to scrub, I was taught to prep grafts, I was taught to first assist in the OR, and did that for about 3 years, I guess. And then made some pretty good contacts who were PAs. And then as I was entering my kind of mid-20s, I said, well, maybe I want to expand myself a little bit more and to kind of see what else is out there. So then I had been working similar to the role of a PA to some degree, working in the OR and in a clinic. So I had some pretty good firsthand experience and really liked what I did. So I said, hey, let me, see what I can do to expand myself and my career. And here we are now.
Awesome, awesome. That's great. So it's great that you already had the basically patient care hours from athletic training.
Mm-hmm.
So can you tell us a little bit more about your journey to PA, how the application process was like for you, and where you decided? I know you ended up going to University of Southern Alabama.
Mm-hmm. Yep. South Alabama. Yep.
Yes, yes. So can you tell us about your journey to actually becoming a PA or getting accepted into PA school?
Yeah, for sure. So at the time, I was living in Pensacola, Florida, which, if people don't know geography, it's basically Alabama.
Yeah.
It's way, way, way in the tip of the panhandle, but still in Florida. So I was in Pensacola at the time. Um, and at the time I was single, I didn't really have a lot of obligations. So I applied everywhere. I mean, I literally applied all over the country to places that I knew I met minimum requirements. And what I mean by that is I was a little older. I was 27 when I started PA school. So a lot of my undergraduate chemistries, biologies, and things like that were going on 9 or almost 10 years. And some programs, have a time limit on those courses. And at the time, I wasn't in a place where I could go back and take, a full year of undergraduate courses. So I just applied to schools all over the country, did my research of, where I met minimum requirements. Because at the time, for me, my priority was going to PA school. It wasn't the location. It wasn't necessarily, a price. It was like, this is what I want to do, and I'll go wherever it takes.
Right.
So I applied all over the country. And then my first choice was University of South Alabama because, like I said, it was almost in Alabama where I lived. It was about a 40-minute drive. So I was really comfortable with the area and with the people and had some good connections, with that. So the application process for me, I had a few interviews. I had a few offers. I originally was actually waitlisted at South Alabama. So I was a waitlist candidate. I did have a couple other acceptances, and I did submit a deposit for a different school. But the benefits of dropping that seat and going to South Alabama, the cost, the location,
Yeah.
the connections I had was worth it to me. So, that experience was interesting, kind of coming off the wait list and seeing how that process went. But that was my top choice, and I waited and eventually got it.
That's awesome. Did you do anything during that time of like being on the wait list? Did you like contact them or send a letter of intent? Like how did you end up getting off? Was it just like randomly or of course fate?
Well, a little bit of everything. So, the way that they did it, they gave a rank of your waitlist number. So I think I was actually like number 7 on the wait list, and I knew the selection was coming up towards the end. I sent an email just saying, "Hey, I interviewed, I don't know, a few weeks ago. I know you guys are getting down to it. I have some decisions to make. I have another couple offers. Where do I stand?" And what they told me is that unfortunately you're not in our the cohort that we're going to give our first round of offers to, which we had 40 in our class. Um, I said, okay. So that made my decision easy because at the time I wanted to go to PA school. So I, like I said, took a seat somewhere else. And then they gave out ranks of their wait list. I was number 7. I think it was, I don't know, maybe 2 or 3 weeks later, after I had, put down a deposit at a different school and got that information, then I got the phone call that I was, accepted there off their wait list.
Oh, that's awesome. It's
Yeah.
great
So
that it happened. Like it all worked out.
it did. Yeah. I didn't go too overboard with the letters of intent. I didn't go up to the school and bang on the door and, ask, but I wanted to get the information that I needed, to make an educated decision. I wasn't going to be overbearing. I wasn't going to be, that guy that's making a lot of fuss about it. It is what it is. And, just do the best you can with the information that you have.
Right, exactly. And I'm sure you save money by staying close to home and
Absolutely. Yeah.
that's great. So, how was the PA school journey like? How was the transition from being like an undergrad or the learning style you had in undergrad to being a PA student and completing didactic?
Yeah, for sure. So I'm seeing a lot of chit chat in the chat that when I said 27, consider older, that I'm getting laughed at for that. So what I mean by that is, I didn't come straight out of undergrad, and I had, I guess, 5 years of work experience, before deciding to go to PA school. So the biggest thing for me was relearning my study habits, relearning, do I need to go buy highlighters? Do I need to go buy notebooks? Do I need to go buy pen? Like things like that you kind of take for granted when you're in undergrad.
Right,
And I had to find a routine for me that worked.
right.
So, having some pretty high stress work years under my belt, I didn't get too overly stressed with the way PA school was. You really have to roll with it. Things come at you fast, things change all the time. The staff and faculty is doing their best. So I've had some work experience that prepared me for that side of things. But the thing that I didn't have a lot of preparation for recently was literally just cramming out time to study.
Yeah.
And like finding a good routine. Whether do I read? Do I watch YouTube videos? Do I write? What is it for me that's going to work? So that was definitely the biggest transition, going from working to back to school.
Yeah, exactly. So, because technically you were like a non-traditional student,
Mhm.
having been out of school for some time and having to
Mhm.
figure out how to like you said, study and be studious and get all that down.
Absolutely. Yeah, definitely a big transition.
Right. Okay, so what was your favorite class in didactic?
Um, Anatomy for sure. We had a cadaver lab. It was the first course. It was one of the first courses we took. It was in our first semester of PA school, um, and it was a pretty awesome lab. We had a great instructor, who was very, very smart, but also very engaging, and willing to teach and take extra time. And we had access nearly 24/7 to the lab, that we could come in after hours, come in early, and work on the cadavers, look at things, look at other people's bodies, because not every anatomy is the same. So that was definitely my favorite class. I actually was fortunate enough in undergrad to have a cadaver lab as well in my undergraduate studies. So I had a little bit of a leg up, just that I've seen that before. I've been in that environment before,
Yeah.
and kind of knew what to expect. And I really enjoyed it. I really enjoyed the hands-on because we actually got to do the dissecting as well in PA school. So we had some instruction, we had scalpels, we had to kind of map out where we were going and make sure you don't cut too deep and things like that.
Yeah.
And I'd worked in orthopedic surgery as a first assist for like 3 years before that. So I was very familiar with how scalpels should be used and things, and get to put it to work was pretty fun.
That's cool. That's awesome.
Yeah.
Because, I was gonna say with anatomy, it goes hand in hand with like orthopedic surgery. Knowing your anatomy really well. I don't like ortho. So it's not my strong point. I actually didn't even like anatomy. Also, we took it my first semester in PA school, but it took a toll on me. But
it definitely can. Some people struggled with it. You either kind of love it or you don't. You're very, it's kind of like black and white. I mean, it just is or it isn't. This is the structure or it's not the structure. So
definitely, I'm more of a pathophysiology girl. I don't know why.
Understand the process.
Yeah. Okay. So we do have some questions already coming in.
Sure.
Someone asked, "How was your timeline? How much did you set aside for the GRE and standardized tests you needed for the programs that you applied to?"
Yeah, GRE. I was working full time, and I probably took on and off maybe like 3 or 4 weeks. I bought one of those thick, I don't know, Kaplan or whatever study books, and went through and did practice questions. Again, being out of undergrad and basic algebra for a number of years, I had to relearn some, equations about angle or areas of triangles and stuff like that.
Yeah.
I'm also a really slow reader, just in general. So the reading passages were pretty tough. So I had to work on my skimming skills, if you will. But I probably took about 4 weeks, 3 to 4 weeks working full time. And then did well enough, I did not have to retake it. I took that, probably in April or May, actually. And then the program I was applying, or the program I got accepted to, didn't have a deadline until September 1st. I think I submitted all my applications maybe by late July, I think it was. At the time, I had to take a medical terminology course. That was one thing I did have to do as a prereq. I took it like the first half of the summer semester. So whenever that finished, June or July, I forget now. But I needed to do that. And then I had interviews anywhere from September through November, I think it was. I got a couple acceptances around November, early December, and then came off the wait list after the 1st of January. I think it was maybe the second week of January.
Okay.
Then,
well, how long did it take from the interview to getting off the wait list?
Probably about 3 months.
Okay.
Yeah.
You persevered.
I did. Yeah, I did. Yeah, it was my first interview, I think, of the cycle. And then I had a couple. So yeah, that might have been too. I may not have really crushed the interview. I didn't have a lot of good interview help.
Yeah. But you still got in.
I still got in. Yeah.
Alrighty. We have another question.
Sure.
Any advice / coping mechanisms for someone that's been waitlisted?
It's kind of a bad saying, but trust the process. It is tough. I have seen now on the inside or on the other side of the table, what admissions committees go through. And the selection process for each program being different is intense and it's in depth. Like I said before, I wouldn't berate a program if you are on the wait list, but definitely get the information that you need. If you need to start thinking about, applying to another school or taking another offer or, looking to reapply the following year, you just need to know. And most programs should be courteous enough and respectful enough to at least give you some sort of honest answer of yes, no, or maybe. They probably can't tell you exactly where, but, just trust the process is really the biggest thing.
Okay, great. Thank you. Yeah. I have a question before we move on. This is a great question.
Uh-oh.
What specifically was it about being a PA that attracted you to the field since you also worked with doctors?
Great question. The thing for me was building autonomy. As an athletic trainer in a physician practice, which is, for those who don't know, it's kind of a hybrid role, kind of a cross between like an MA, a nurse, and an administrator. I saw all facets of the practice and I helped with all facets, anything from budgeting, to ordering supplies, to rooming patients, to taking out sutures. I kind of did everything, sort of a jack of all trades. But what I didn't have was the independence to do those things on my own. As an athletic trainer, you're not a billable provider in most of the states. So therefore, my earning potential was a lot less. And also, what I did was in such a small niche that, let's say, I met somebody, I moved, I had to, travel to a different state for family, or the provider I worked with, he retired and left. I didn't have a lot of, and I hate the word lateral mobility, but what I did didn't translate well into other opportunities. So if I left my job there, I would either have to go back to sideline athletic training, either in collegiate or high school, and I knew that it's not where I wanted to be, or I had to find something else to do. So, sorry, to roundabout question, what about the PA? At the end of the day, it was independence and it was flexibility and adaptability with my career and with my life.
Okay, awesome, great answer. Thank you.
Yeah.
So we're going to move on to rotations. So the rotations being on clinicals like for you, and why? So you decided to go into ortho not necessarily because of rotations, but because of your past experience, right? Okay.
Yeah. So by and large, I really enjoyed clinicals. It's a very refreshing thing to not be sitting in a classroom for, I don't know, 15 months or however many months it is in didactics. So just getting out of the classroom was a nice change of pace. My program set up all of our clinical rotations for us, so we did not have to worry about that. We were part of a large academic institution, so we had a university hospital, which was a teaching hospital with med students, residents, nursing students, PA students, and everything in between, which was a great resource for us to be able to collaborate with other professionals. I was surprisingly enjoyed rotations I didn't think I would enjoy, such as like women's health, OBGYN. Like I actually really liked the delivery part of it, and almost thought about pursuing some opportunities in that after PA school, as well as pediatrics. I actually, out of my own time, or rotation it was, but elected to work in a pediatric ER for an additional month because I really liked it. I don't know why. Again, things that you don't think you're necessarily going to enjoy, you just kind of come to find out that you like them.
Yeah.
And one of the biggest things that I learned on rotations is that who you work with and who you work around almost supersedes and makes the job more so than what you do. I had an ortho rotation that was kind of okay. It wasn't the best preceptor, but it was ortho, right? You'd think that I would love it, but the learning environment, the situation wasn't as conducive or inclusive as some of the others. So taking into account who you work around and learning from that, whether you may or may not like the subject, is just as important in your career as getting enough information to pass the EORs.
Right. Yeah, that's awesome. That's great advice, and I completely agree with that. I didn't think I would like surgery at all, but my preceptor was amazing, and I ended up liking my general surgery rotation. Same thing with ER. I really liked ER. I mean, I ended up doing, but yes, he's very right, spot on that. And I wanted to actually backtrack a little bit because you said that your campus was also had it was a university hospital, and you also had medical school students, residents, and whatnot. Did you take classes with the med students?
We did not. Our PA program was set up entirely independent of anything med student or nursing student.
Okay, cool. And then what about rotations? Did you have rotations with med students? Or?
Yeah, so we did, like when I was in the ER, there's a couple of ERs in the town, but the big one was our university hospital. So there was PA students, there was med students, there was nursing students, all in the same ER at the same time. And that was sort of to be expected. And the preceptors there, they understood the demands and they understood the relationships between all of us, and actually did a pretty good job. And there wasn't a lot of competition.
Right.
I think that's probably what we're getting at was there competition with med students and stuff like that? Yeah. I mean, if you just sat there and you had a patient that was, needing their belly tapped or something, for example, and you didn't kind of get up to do it, they would offer it to somebody else. I mean, so in that case, yeah, but if it was your patient, they would honor that, you're the PA student, you get to do it if you're working with somebody.
Right. Thank you for that.
Hmm.
Okay, we'll answer a few more questions and then move on to your post PA school life.
Sure.
Um, okay. Someone said, how much time and effort did you dedicate to the personal statement? I'm having a hard time writing it.
Honestly, maybe not as much as I may have should have, but I don't know. I think I had enough life experience to draw from. I found that working with some pre-PA students that sometimes people struggle. Especially the last couple of years, it's hard to get some experiences. Um, as far as how much time, gosh, I couldn't maybe a month or so, maybe a month to 6 weeks from the time I started brainstorming to the time I was confident that I was ready to submit. And even at that, are you ever really confident to submit it? I don't know. But
Yeah.
anyways, probably a month or 6 weeks. And, I did get some help with it, but I tried not to get too many hands in the pot. I've noticed this too. If you ask for 10 people's opinion, you're going to get 10 different answers, right? And as the applicant, as the student, you got to, at the end of the day, write an essay that reflects upon you, not somebody else's ideas of you. So I don't know if that answers the question, hopefully.
Oh, that was a perfect response. Thank you for that. Okay, and with orthopedic surgery being predominantly male, how would you advise a pre-PA female student who's interested in orthopedic surgery to how to overcome the obstacles in a more male-dominated field?
Go for it. I mean, that's the biggest thing. You got to kind of jump right in. Yeah, to some degree, it is, if you look at the stats, dominated by males. But that being said, I've worked around both physicians and physician assistant females that have been awesome. I mean, rock stars. There is, to some degree within each specialty, a little bit of like a culture, if you will, kind of a mentality or personality that sort of comes with, the field in each specialty. And that's not just ortho, that goes with derm, that goes with, family med and stuff, just kind of the way people think and act. But being a female, I mean, by all means, jump in, just be confident in yourself. You have just as much ability as a male, as a male student or incoming PA. So don't be shy. That's the biggest thing. Have confidence and be confident in yourself. Your mindset is everything. And if you feel like you're not good enough or not worthy enough, then that'll come through, whether it is or is not true.
Yes. Thank you.
Yeah.
Righty. So you went to PA school, finished,
Mm-hmm.
graduated. Next
Mm-hmm.
thing is getting a job.
Getting a job, yes.
What was that process like? Going from PA student to new grad and having to find a job. Did you actually already have a job offer while in school, or did you have to go through that time period of applying to jobs, getting a bunch of no's, and then finally landing one? How was that like?
Yeah, good question. So I was in a little bit of a different situation. I knew in like the first of the year, so we graduated in July. I knew around December, January, where I was, because of family situation, that I was moving out of state to a different city. So I started looking 6 or 8 months before PA school finished. Started looking and seeing what was out there and just getting my name out there, even if it means applying to the same institution a couple different times for a couple different positions. Not having connections in a different city or a different state and different city was very tough. As you get older and you learn, your connections and who you know does make a big difference. I was moving to a city that I had no connections whatsoever. So it was very, very tough to try to break into any of these bigger institutions sort of as a nobody new grad.
Right.
Especially out of state, who they don't know you, they don't know any of your connections, right? So I started looking early. And I had a few kind of phone interviews and stuff anywhere from April, May-ish, going into June. And our program was actually set up quite nice that it allowed one of our electives to be done sort of anywhere across the country. They would help create a new preceptive relationship with a different provider. So I made a connection through a friend in the city that I was going to with an orthopedic surgeon. So I actually did my elective I moved from Alabama to Wisconsin. I actually did my elective for PA school in Alabama. I did it in Wisconsin. So I went up there for a month, stayed, worked with this orthopedic surgeon for 4 weeks for the rotation as an elective. It sort of as like a trial job opportunity, if you will. He was looking to hire. I was looking to move to the area. We actually became pretty close. I actually did not end up working for him, just the way that the job and contracts and stuff worked out. But him being an orthopedic surgeon in that city, he put in some good words for me with some other folks, and very much helped me get the job that I ended up getting right out of PA school.
Right.
So
And that's
yeah,
orthopedic surgery. You did that straight out of PA school.
I did straight out of PA school orthopedic surgery. Yes, correct. So that's rotation, elective rotation. Really, even though I didn't end up working with him, he ended up helping me, making some connections to getting a job opportunity. So we graduated in July. I think I got offered that job in August. I think I took PANTS first part of August, and then a couple of weeks later, I ended up getting the job offer in Wisconsin in August. And then I think I started like the 1st of October because of credentialing, onboarding, all
Yeah,
that stuff takes a good 3 months that
it does.
people don't talk about it, but it takes a while.
Exactly. And yes, PA schools don't tell you anything about
Yeah.
credentialing process for hospitals. Credentialing basically means like the process you go through to turn in all the paperwork and stuff and background check to make sure that you are who you say you are. You're going to be
Hmm.
working for a hospital, so it's like doing a due diligence to get everything done, and it's like a 3-month process, guys. So schools don't teach you that. So it's not like
Yeah.
if you get a job right away, or after graduating, it'll still take a few months to actually start.
Hmm.
So
And that's
yeah,
one reason I started looking super early. I knew it was way too early, but you're better late than never.
yes,
And then once you graduate PA school, like your loans may be allocated up until when you graduate, right? And if you graduate end of July, you have all August, all of September, October. I mean, that's 3 months before
right,
and then you may not get paid right away for starting a new job. That's 3+ months that you go with theoretically not a lot of money, right? So again, people don't talk about this, but y'all need to kind of know, what to look for.
exactly, exactly. And I think I forgot to mention, but I did put David's IG at pre PAC Consulting. Um, but David is a mentor. He has his own platform at pre PA pre AC Consulting. So I'll put his Instagram again. Feel free to reach out to him. He really enjoys helping all of you. So
Yeah, I like telling you guys what I wish I had known when I was in your seat.
right, right, right. Yes. And he's also on the Med Assembly team. So David is awesome.
Super
Definitely
excited.
following him. So yeah, so can you tell us about that learning curve going from, PA student and being in the specialty, such a
Hmm.
I don't know how orthopedic PAs do it. I know it's very busy. I'm sure you were on call. I'm sure you have to get down not only surgery, but just being an ortho and all the crazy traumas that you probably see. So
Yeah.
tell us about that learning curve. What kind of training you got, and when you finally were able to feel comfortable practicing, autonomously.
Hmm. Yeah, for sure. Even with, my 3 years of working in a orthopedic surgeon's office before that, I still was a little nervous being, the solo provider for a patient on your own. Um, I actually, luckily, did not ever have to take call with my PA job as an ortho. So I've never actually taken call with an orthopedic job. Those jobs do exist. They're few and far between, but they exist. Um, but it probably took about 2 to 3 months, I think, before I started seeing patients on my own. And that was in part due to the institution as well. They go through sort of an onboarding process that was quite thorough. Made sure that I knew my way around the hospital, made sure I knew my way around the EMR, made sure that I knew my way around the clinic. So that way, when I was ready to start seeing patients on my own, not only did I have the clinical knowledge, but I had the intangibles to be able to be successful with that. So they were very good. It was also an academic teaching hospital, so they knew about learners and new grads and new hires and stuff like that. So probably about 2 to 3 months, I think, until I started actually seeing patients on my own. And in that 2 to 3 months, I did work with my collaborating physician, and I would basically shadow him the first couple of weeks to learn his tendencies, learn the common things, learn how he likes to practice, learn post-op protocols, learn the EMR. And then for the next month or so, we started doing kind of a half and half deal where I kind of went back to student role, where I would see a patient, kind of come up with my assessments, my plan, and then present to him. And then we would go back, and kind of wrap up the patient together. And then I would, do the clinical note after that. And that went on for about another month, just so he could get to know me and know my tendencies and my comfort, as well as, me know his comfort as well. And then after that, then I kind of started rocking and rolling on my own. The surgery part was actually easy for me because I'd done that.
Right.
Being an assistant in the OR, I'd say you're always learning, but once you get the basics, that's a little easier than clinic to some degree. Because as a PA in surgery, you're never on your own. Obviously, there's always a surgeon there, and you're just helping to assist. So that learning curve for me was a whole lot quicker.
Right. Okay. Someone said, did you feel prepared as a new grad, or do you recommend completing a residency program?
So me personally, I felt very comfortable going into an ortho job as a PA because I'd had 6 or 7 years in sports medicine orthopedic experience before that.
Right.
My advice, if you can get an ortho job or a derm or ER, if you can get the job you want straight out of PA school, I would say go for it.
Right.
If you can find a collaborating physician or an institution that's willing to teach, do it for sure. Now, if you're not so sure of your skills or you're not really sure what you want to do after PA school, I think residencies do serve their purpose. I think for a subset of individuals, where if you want to do ortho, but you're just not strong in it, you've never had any experience prior to PA school, you know that your opportunity or your chances of getting a job opportunity are slim, then a residency makes some sense. And it also may confirm that, hey, like, this isn't for me. When you sign a contract or you start a job as a PA, your first job is never going to be your last job, but you don't want it to be a job for 2 or 3 months and then you find out, I hate this.
Yes. Thank you. So, all right, before we move on to the case study, can you walk us through a day in the life of an orthopedic surgery PA, from when you clock in to clock out, and how your days are, patients you see, cases, and
Yeah, for sure. So the way my job was structured, I was pure salary. So I did not ever clock in or clock out. I just would come and go, and you're just paid for if you work 4 hours a day or 14 hours a day. So that's that. A surgical day, I would get to the hospital about 6:30, and we would start cases about 7 or 7:15. I would see the patient in pre-op. I would make sure the pre-op nurses have all the orders that they need, make sure they have the pre-op and the discharge orders, the post-op meds, things like that. Make sure the patient's there, first of all, and all that kind of stuff, and kind of get everything just sort of rolling and sort of warmed up for the facility. And then I would go to the actual OR itself in the back, and then I would make sure that the scrub tech and the circulating nurse have all the equipment that they need. As a PA, surgical PA, one of your jobs should basically be to foreshadow what could go wrong. And you want to know what your surgeon might need before they even think that they might need it. So,
right.
Having 2 or 3 fail-proof steps beyond what normally expected is very important. So making sure your reps are there if they're using some sort of implants, making sure that all your trays and your instruments are there, sterilized, and everything is ready to go. Because the OR usually should run on a tight ship, meaning when it's 7:15, the patient's in the room. If the case takes an hour, you do your thing and everything should be, you're pretty methodical. So making sure things are ready to go to get started is very important. Each case may take longer than anticipated, which is fine, but you may want to make sure you get off to a good start. We would do anywhere between 3 and 7 cases a day. I worked at a time primarily with a foot and ankle surgeon. We did see some trauma. We were a big level 1 trauma center, so we got a lot of car accidents, people falling off ladders. So I've seen some pretty gnarly foot and ankle injuries. I think the longest surgery I was ever in was in 6.5 hours for an ankle. That was pretty rough.
Oh my gosh, that's the whole day.
It is well, yeah, it can be. So that was a big one. Most of the cases were probably about 2 hours or so. Um, and then, like I said, 3 to 5, 7 cases a day, depending upon what we had scheduled in the time of the surgery. We know going into it about how long they'll take. Most days, I'd get there at 6:30. I'd probably leave by about 4:30 or so.
Okay.
Occasional times I did stay there after 7 or 8 o'clock at night. So you're working, a 13 or 14-hour day, and that can happen. It's
Right.
rare, but it can happen. I've also worked 2 cases and been done by noon, and you go home and you're done for the day. That's it. In clinic, I would see anywhere between, I don't know, 18 and 24 patients a day on my own. My collaborating physician was sometimes in the building. He was sometimes not, depending upon what his schedule was. And those patients were mine. I mean, I'd see him in follow-up. And then if they needed something surgical, then I would address what that may be and then put them on the surgeon's schedule for his next clinic day. And then, they could set up surgery and stuff at their convenience.
Okay. And what were your surgery days versus clinic days?
We were in clinic Monday, Wednesday, and then surgery Tuesday, Thursday, sometimes Friday.
Okay. Yeah. Oh, so Friday is not, it's not like, oh, get off early type of day.
Not always. Usually Fridays were reserved for those big, long 4 or 5 hour cases because, we would usually schedule one and then you don't have anything behind it. You can take as much time as you need.
Okay.
You know.
Awesome. And did you also ever see like the ER consults by yourself, or you would go down with the doctor to see the consults?
So not so much, honestly. We had residents at the hospital. So residents were first call residents were in the ER. So me as an ortho PA in that particular role, I did not. If the PAs with the trauma orthopedic surgery team, sometimes they would go to the ER, but it was mostly covered by residents.
Got it. Thank you.
Mm-hmm.
Alrighty. And just answer one question. Someone wanted to know, did you feel prepared for the PANCE? Did you feel like your school adequately prepared you for the PANCE?
I did. I took the PANCE literally as soon as I could after graduation because I wanted everything to be fresh in my mind. I think, I don't know, it's maybe, forget if I'm wrong, maybe 10 days or something after you actually get your degree, graduate, that you're eligible to sit for it or maybe eligible to schedule. Forget, but it was within just a couple weeks. And yeah, I felt confident almost to the point where I was like, oh, I don't know what to study because you don't want to overstudy and overthink things. I'm not trying to sound cocky or confident, but I just felt that the more I would look at material, the more I would confuse myself.
Yeah.
And you just have to kind of, trust your gut and trust your judgment. And I felt very well prepared throughout my PA school program.
Yes. Thank you. And just one more question. Sure. Okay. Do you feel that the physicians overall respect you as a PA?
Overall, yes, I do. I've worked in mostly academic institutions where there are learners and they are usually quite aware of what a PA is and what a PA can do. And a lot of that testament goes to PAs in those institutions for being on administrative boards, being on faculty boards and things like that, in showing that you're more than just an assistant, that you actually are, a valuable healthcare provider.
Yes. Thank you. Okay, guys. I know you.
I talk a lot.
We're going to move on to the case study. We're going to have David share his screen so we can go over the case study. He has a great case study prepared for everyone tonight. And of course, if we didn't get a chance to go over your question or answer your question, just feel free to message David or I. And yeah. So,
all right. Let's see if we can make this work. Yeah, and I'm happy to answer questions towards the end there too. This case can get kind of long, I can be kind of long-winded if you haven't noticed, but I'll try to fly through this and get to the good stuff.
Thank you.
All right.
Are you able to share your screen? It's should be at the top of the monitor. Yeah. Should say turn screen share.
Yeah, hang on. No Sorry, I should have done this earlier.
No problem. Let's see.
Does that work?
No, I don't see the screen.
Okay.
Let me know if you guys see it. I don't see the screen yet. If you want to, you can also upload the slides directly. If you see on the corner, it should see like the little slides icon. You can add a new presentation and do it that way. If the screen share is not working.
Sorry.
No problem. Great.
How do I send it to you, or how do I upload it real quick?
You see the slides? You see the icon? Like it should be to your right, next to the chat box.
Oh yeah, here you go.
Yeah, you'll click slides and you can add a new presentation.
Sorry.
No problem.
Should have troubleshooted this with this earlier.
That's good. It's good.
We can just sit and talk all night.
I'm sorry?
Let's say we could just sit and talk all night. Answer more questions.
Yeah.
It says it's uploading, but it's a big file.
Okay. Now we can probably answer a question while it uploads. Let's see.
Sure. Happy to.
Someone asked, let me look at the Q&A. How essential do you feel like a cadaver lab is for your specialty? Because some institutions say that they elected to forgo a cadaver lab. Would I still be able to train through for surgery? Yeah, you can still train for surgery, but how essential do you feel like you going to a school that had a cadaver lab helped you with your job?
I mean, it's important. Would it make or break getting a job in surgery? I don't think so. It would prepare you better for your clinicals, maybe. You may just have to work a little bit harder, watching more YouTube videos, or doing more on your own independently than if you otherwise did have a cadaver lab. But I think if you don't, you still have enough resources to be able to do well in your clinicals, to get enough knowledge to then, especially get a job. I don't think a cadaver lab would make or break you getting a job for sure.
Okay. And did you study in study groups or by yourself?
I was kind of a loner. I worked by myself for the most part, but that's just because I knew, it took me a while, but I figured out the way that I wanted to study and how it worked best for me.
Right.
And it very much was, do things on my own, study on my own, read on my own. Every once in a while I'd work with groups, but not super often.
Right. Okay. Let's look at another question. How many schools did you apply to? Or how many would you recommend applying to in order to increase your chances?
So I think that's sort of a loaded question to some degree. I think I applied to 7, and I got 5 interviews for technically then 4 acceptances. But I was, again, pretty focused on only applying to schools I knew I meet minimum requirements, and my situation required just, a particular number of schools based on my background. Now, if you can only, and I use this example a lot, like if you live in Dallas and you have family, you have kids, you own a house, and you can only live in Dallas, like you can only go to PA schools that are drivable, then, that limits the schools that you can apply to. It may be 3. Now, if you're like in my case and you're fresh out of undergrad and you have classes that transfer and go anywhere, you can apply to 40 schools if you meet the minimum requirements. So it's a tough question to ask, or a tough question to answer. I would say on average, I probably see anywhere between like 8 and 12 is like an average number that I probably see.
Okay.
I think this thing is uploaded now.
Okay, so you would click on it and yep, here we go.
There you go. All right. All right, so we'll run through this real briefly. So this is a chief complaint of a 52-year-old white male who says, my shoulder is killing me. So in the HPI, and I highlighted these these little yellow things for a mnemonic called old carts, which is, you guys may have seen this before, but it's basically a mnemonic to help you answer the questions that you want or you should need in your HPI, which stands for your history of present illness. So as a 52-year-old white male presents with white shoulder pain, he states that 10 days ago, which is the duration, he was on a skateboard being pulled by his dog when he fell to the ground on his right side. So that's when it happened, the onset. He describes the pain as a constant, T for timing, ache, A for characteristic, over the lateral aspects of the proximal right upper arm, which is locate, L for location. He says the pain is worse with overhead movements, which A is for aggravating factors, and lessened with ice and Advil. R is for relieving factors. He states his pain 8 out of 10 at the worst, 2 out of 10 at the rest. S is for severity. He states that he has never injured his right shoulder before. This is the first time being evaluated for this complaint. His current complaint is preventing him from doing work and recreational related activities. Denies any LOC, which is loss of consciousness, or any other injuries from the fall. Social history, which is very important actually in orthopedics. I really like to know what do they do and what do they like to do. Because in ortho, you should have some sort of goal that you're trying to get people back to, even if it's very simple, just walking, but somebody should have a goal. So he works as an electrician, which is a lot of overhead work, and also as a youth baseball coach. Any good clinic note should have your past medical history. He has hypertension, which is controlled. A review of systems, a good 8 or 10 point review of systems should be documented, at least for your HPI. Basically, he denies everything except just some shoulder pain. And when you get an HPI or a history and you're thinking about what they're telling you, you can start to formulate what's called a differential diagnosis, which is basically a list in your brain of like, what could this possibly be based on my medical knowledge, based on my experience, what could this theoretically be at this point in time? So some things to consider: it could just be a contusion or a bruise, could be an AC joint sprain or separated shoulder, could have a labral injury, rotator cuff injury, proximal humerus fracture, or possibly shoulder subluxation. So those are kind of big major things that can happen with this type of mechanism. We won't go too much in depth with this physical exam, but basically he has some tenderness at the AC joint, which is the top of the shoulder. His AROM, which is active range of motion, is limited, meaning it hurts for him to actively move his arm versus you as the clinician passively moving it for them. Some special tests. Basically, these show that he has some impingement signs and basically pain with moving his arm kind of up and over his head, and a little bit of rotator cuff pain. And just for the purpose of this, guys, we'll just kind of go through this briefly to get to the better stuff. With this, the differential diagnosis, as you start to, and this goes for any specialty, as you start to learn more about your patient, and in this case, it's due to the physical exam, you can start eliminating things off your differentials. So eventually your differentials will, you like cast a wide net and you think about a whole bunch of things and you eventually narrow it down to what is this most likely to be. So we ruled out a couple of things, and now we're thinking contusion or impingement. And impingement is basically swelling or fluid between the rotator cuff and the bone on top, which is called the acromion. So everybody in ortho gets x-rays. So here's a couple of views of some shoulder x-rays. Essentially normal, no fractures or anything like that that we can really see here on the x-ray, but these are just some common views that you would see in a shoulder x-ray. So just real quick, this is the humerus, this is the ball, kind of the ball, and this is the socket. This is part of the scapula, also called your glenoid fossa. And this right here is what makes up the actual shoulder joint. This is the subacromial space, meaning this is the acromion bone here. And then this is the subacromial space. Can you guys see my mouse moving or no?
I can't see your mouse.
No? All right. Well,
I don't know.
That's all right. We'll just keep going. So for this particular case, we ended up getting an MRI of this guy's right shoulder. And some people may say, why? I mean, that may be too early. But he has multiple positive rotator cuff findings on his physical exam. He has negative x-ray, but still significant dysfunction. And he's an active guy, and he's not able to do what he wants to do. So if something needs to be done surgically, he and the provider may want to be a little bit more aggressive. If he was more sedentary and could kind of live with the way his symptoms are, you may not jump right to an MRI. On this MRI, we found that he had a partial thickness, articular-sided rotator cuff tear, and a little bit of AC joint arthritis. And we'll talk a little bit about the difference of why articular-sided is what it is. So here's a couple shots of an MRI. We'll start the one on the right, which says normal is normal, and where we're looking at is just to the right of those red arrows. The one in the middle, you can see a small white circle that's just to the right of where that red arrow is. And on the image all the way to the right, you do not see that. It's perfectly black all the way through. So the perfectly black all the way through on the image on the right is the rotator cuff. The little white spot that you see both in the middle and the left pictures near the red arrows, that is swelling or inflammation, aka indicative of he has a little bit of a tear in his rotator cuff at that spot. And there's fluid there, which would normally be the tendon. And on an MRI, fluid shows up in white. So his assessment plan, he has a partial thickness rotator cuff tear. We talked about conservative measures such as rest, physical therapy, as well as surgery. And again, because he's active and wants to kind of get back to doing what he wants to do, we talked about a shoulder surgery, which is called an arthroscopy, which means arthroscope, which means look inside of a joint. And then there's a couple other procedures with it that we'll talk about. And then the possible augmentation is kind of the unique part of this particular case. And it's a type of surgical technique that I'll show here. So you may say, okay, what does surgery look like? I don't know. But this is a picture from an operating room. The person to the front on the right that you see is the surgeon. He has a little camera in his hands. The patient's, this is a right arm, so the patient's right arm is up in the air. They're lying on their left side. So the little blue part you see kind of the bottom left of the screen would be the patient's left arm. So the patient's laying on their left side with the right arm suspended in the air. The individual kind of in the middle there that you can see just to the right of the arm, that's the PA. So the PA is right there with the surgeon and helps with instrument transportation and moving things around. And then on the shoulder, you may see there's a little bit of a line. That's a marker that's used to draw out your anatomic landmarks. And those little blue holes are called cannulas. Basically, there's little holes inside of the body that you use to put the instruments in and out of. And it holds that in place so that way you don't lose your spot. Because if you put a needle in a muscle and you take it out, the muscle is going to kind of squish back together. So those cannulas keep an open hole that you can pass things in and out of. So here's some arthroscopy pictures or pictures inside of the shoulder. What you see is a little metal device coming in here. It's called a probe, and that is going through one of those cannulas, which you can kind of see is that plastic tube. What you're visualizing here on the top part is the biceps tendon, and then the kind of bottom flat part in the middle is the glenoid fossa, and to the right would be the humeral head. So this is just an inside, this is all normal. There's nothing wrong with this picture. This here, you can kind of see better the ball and the socket. The socket would be off to the left. It's actually more flat than round. People think it's like a huge curve of a cup. It's not so curved. It's a little more flat than you may think. But that flatness is what allows such a huge range of motion in the shoulder. I mean, you can move your shoulder 180 degrees essentially, or 360 degrees. And that's because the cup, if you will, is relatively flat. If this had a huge hook or curve on it, the ball wouldn't be able to move as much. So a flatter cup allows more rotation from the ball. So again, this is the humeral head into the glenoid fossa. And again, this is relatively normal. This little wispiness is not too uncommon, but could be a little bit of arthritis, but relatively normal. So here's a picture of the rotator cuff. This is looking from inside of the joint, kind of up at the rotator cuff. And the picture on the top and left is normal. You see that tendon is the kind of wave-like looking thing that's very flat, very smooth. And that's a normal picture of a rotator cuff. The one on the bottom right, you can see there's kind of a wispy, grass-like little appendages, if you will. And that's a partial tear, meaning that tendon that was there has kind of come off and kind of partially torn. Hasn't completely ruptured, but it's kind of partially torn. And then the instrument coming in is a little shaver that is used to kind of clean up little wispy parts that kind of like mowing the grass, if you will, for lack of better terms. And this is what's called the articular side of the rotator cuff. Basically means it's inside of the joint. It's near the articular surface of the humeral head and the glenoid fossa. And that is in contrast to what's called the bursal side. So now we are technically outside of the shoulder joint. We are in that space between the rotator cuff and the bone above it, which is called the acromion. And this is a top-down view. This is what the rotator cuff looks like. This is intact. This is nice and pretty and neat. And there's no tears here. This is a little bit of a hook on an acromion. This is likely what's causing the patient some impingement. It's kind of V-shaped. It kind of comes down sort of like this in the middle. That should be relatively flat, but that V shape is a little bit of arthritis and a little bit of overgrowth of this bone that eventually gets kind of cleaned up. That can cause pain, cause impingement. As you could imagine, if this smooth rotator cuff on the bottom is rubbing against that jagged edge, it's not going to feel too good. This is a picture of the AC joint, or the acromioclavicular joint. When somebody technically separates their shoulder, this is the joint that they're injuring. This sits on top of the shoulder, kind of up right on top of here. This has a little bit of arthritis, just it's kind of rough and ragged and jagged looking. So this gets cleaned up, and this is what it looks like after you clean up this bone, and you take it down to this sort of healthy bleeding bone. And you create more space between the two, and that's kind of the purpose of that, and it reduces some of that impingement. All right, and now we'll get to, this is what is called an augmentation of the rotator cuff repair. So this is an implant. I don't have any stake in this company. I just think it's kind of a cool implant that gets put on top of the rotator cuff and eventually gets sort of absorbed and acts as a scaffold. This is made from bovine-derived cartilage, and again, it acts sort of as a scaffold, and then the rotator cuff will incorporate inside of this patch, and the patch gets put on by these silver clips, which go into the bone, and then these purple clips, which are like little staples that go into the rotator cuff itself. And I have some video. I don't know if I can share this. Ooh.
Yeah, we can see if it works. Able to click on it.
Are you able to open it by chance?
No, can you send it to me? Put it in the chat? Maybe we can put it in the chat, and then I can share my screen. Or you can put it in the chat, and the students can take a look at it and click on it. Mm-hmm. But that was incredible, like the pictures and your explanation. Like, you really explained it really well.
I try.
Is not my thing, and ortho is especially not my thing. I hate getting all ortho cases.
Yeah, so you need a lot of anatomy to know a lot of anatomy with ortho, and it comes with time. And somebody asked about like a cadaver lab. You don't have to do it. I mean, I didn't learn this stuff overnight. This took me years to really get comfortable and confident to, like, spit it out quick. I just put the video in the chat. And then I do have a couple more pictures here real quick to just finish up. The video basically shows how this implant gets put into place. This is what it looks like when it's complete. This is from our actual patient. And again, these little purple clips are little staples that get added on top. So imagine you have kind of a tear like this, and you add this patch on top of it, and then your body sort of grows into it and uses it as a scaffold to make it thicker. Where you had a partial surface, or a partial tear of the rotator cuff. If it's normally this thick, now it's this thick, you add a little patch on to make it a little bit thicker, and then it all kind of grows in together and gives it more strength. And again, this is kind of a quick cursory overview of all this. I'm happy to dive into more detail if anybody. I know we're getting close to time here, so I don't want to don't want to bother anybody else. Yeah, so we'll power through it quick.
Yeah, no, that was awesome. Thank you so much. So I wanted to know, what's the recovery like for someone after the surgery?
Yeah, so this is a relatively quicker recovery. So this person would probably be in a sling for 2 to 4 weeks. and start therapy. So this is an advantage to somebody that has a full rotator cuff repair. Usually people think rotator cuff repair, you can't do anything for like 6 months, it's a long repair. This is more of an augmentation than a true takedown and repair. So this is a good procedure because it's quicker recovery. It's less downtime for the patient. So he's probably in a sling for 2 weeks, maybe, kind of wean out of it over the next 2, starts physical therapy, probably right away doing range of motion. We'll probably start doing strength at about the 2 to 3 to 4 week mark and gradually increase. He's probably back to playing, or at least coaching little league baseball, probably around like 3 months, 3 to 4 months.
Okay. Thank you so much.
Yeah.
Someone asked about you switching from ortho to urgent care.
Mm-hmm.
Or it seems like a few people want to know why you switched from ortho to urgent care.
Sure, good question. So as you guys know, my background is all orthos, ortho heavy, and that's what I've always known. But you go to PA school and you learn a lot of cool non-orthopedic things, and I didn't want to lose that. I went to PA school for a reason and learned all those cool things for all those months and hours spent studying. So I wanted to keep up with my general medicine. So I originally started sort of like moonlighting nights and weekends. So I had 2 jobs basically. I worked full-time ortho and then PRN urgent care. I've since moved out of Wisconsin, and now where I'm at now, explore job markets for both ortho and urgent care. And honestly, for my work-life balance, the urgent care is better for me right now in this time and place in my life.
Yeah.
I can work half days. I can be off for a few days. When you're on, you're on. When you're off, you're off. So the opportunity for me now to be full-time urgent care is just a better work-life balance for me. And you can find that with ortho. You can have a great work-life balance with any job. It's more the job than the specialty though. And right now that's just what's best for me in my, would I love to be back in ortho? Yeah, probably. But I'll take a little sacrifice to do what's best for me in my time, my free time, my family time.
Yes. Thank you. Flexibility. You were
The
able.
flexibility. Yeah. But that's the thing about being a PA. You can do what you have to do based on your life situation.
Yes, thank you. Okay, so we have a great question. One last question before we go.
Mm-hmm.
Would this augmentation be recommended for, say, a D1 collegiate athlete or the more traditional rotator cuff repair method?
Good question. Ideally, you would not have a big rotator cuff tear in a collegiate athlete. Rotator cuff tears are usually seen in folks that are 40, 50 plus. An atraumatic or a non-trauma related rotator cuff tear, especially a full tear in a collegiate athlete, is relatively rare. I've seen it in some like professional football players, but it's usually from like a bad tackle where their shoulder gets totally dislocated and really torn up. That being said, I would try not to operate on a collegiate athlete rotator cuff if possible.
Yeah.
That'd be step one. If depending upon what the case is, yeah, this might be a good option for them because it's a quicker recovery than a true takedown and repair. But each case is different. I mean, it's hard to truly say. That's kind of a tough one.
No worries. Thank you
Yeah.
so much. You're
My
getting a
pleasure.
love in the chat.
My
Really,
pleasure.
they enjoy the pictures and the presentation.
Yeah.
So thank you.
Good. And do you want me to stay on to answer any other questions, or are we all set?
Let's see. I don't really see any other ones. I think we got. Oh, I see something about. I don't know if the student is still on about spine cases. When does it go from ortho to neurosurgery?
Yeah, spine's kind of a tricky one. If it's usually more bony related, it's probably more ortho. If it's more disc, if it's more nerve entrapment, more say tumors, but schwannomas and stuff like that, it's probably more neuro. But if it's like if you're like a laminectomy, that's more bony. Or if it's trauma, fractures, or if it needs to be someone needs a cage or fusion, that can be more ortho. Fusion could be both, but it could be more ortho. There is a lot of crossover between ortho and neuro. Yeah, and in spine specifically.
Yes, that's true. Okay. Yeah, I think we got just about all the or majority of the questions.
Hmm.
I don't see any that we didn't really touch on. Yeah,
Okay.
okay. Thank you so much, Dave.
Yeah, my pleasure. So we didn't get the screen share working right, but hopefully at least got a little bit of information.
No, you've been great. Make sure to follow him, guys, at Pre-PAC Consulting. And once again, thank you. Thank you again, David.
My pleasure. Thank you guys. Hopefully we'll see you soon for something else.
Yes, yes, we'll definitely be back. We'll definitely want you back. And we'll see all of you next week for another session. Thank you again, David.
Yeah, thank you. Thanks for having me.
Good night.
All right, bye.
All right, guys.